Thank you, Frank, for the introduction, and thank you, Manos and Manos, for the kind invitation. And I was lucky to make it on time, so I'm trying to be on time. Talking about biologic enhancement, what can we expect? So this is my disclosure. Basically, we have two types of enhancement, a single stage and multiple stage. Single stage would be the surgery, and multiple procedures or multiple stages would be medication or vitamins. So as you see, single enhancement surgery would be microfracturing of the insertion, which would be the bone marrow stimulation technique. And then we have cell-based approaches, stem cells, PRP. I will not talk about non-cell-based approaches because that will be too much information in this short window. And then we have also the multiple procedures, which include vitamins and medication. And the question is, why do we talk about biological enhancement? Because we have these high failure rates in the literature, 20 to 40% for small and up to 94% for massive and chronic tears. But is this really true? If you go back in all these articles, they always recite the same paper. I think if you go on a more recent publication, looking at 1,600 cases, I think we are much better than 94%. I think 13% is the more realistic rate we are looking at. So the problem of cuff healing is that we have a slow cell division, we have a reduced blood supply, and also we have a slow metabolism. And this leads to degenerative changes. So the tendon healing basically needs four components. We need proteinate cells, we need growth factors, we need a scaffold, and we need a vascular supply. And due to the poor vascular supply, we have also a poor healing. The normal zonal insertion of the tendon goes from tendon to unmineralized fibrocartilage, mineralized fibrocartilage, and bone, as you see on the right side on the picture. On the bottom right down, you see a repaired cuff tendon. It looks totally different because we have a fibrovascular scar tissue, and this is much weaker than the native structured tendon. And this is the reason why we have tendon failures. So I will talk about the concept of bone marrow stimulation. I think that's a concept every shoulder surgeon is using, debridement of the footprint, trying to get some blood out of the footprint. And this is the most recent systematic review meta-analysis I could find about it. This is an analysis about 4 studies, 2 level 1 and 2 level 3. They investigated 365 patients, and they could not find any significant difference in clinical outcomes. But they could show that they have a reduced retear in the group using bone marrow stimulation. But this is the pooled data of all 4 studies. If you just look at the level 1 studies, pooling the data from those 2 studies, they could not show any difference in retear rate. What's about the cell-based approach? We know all about PRP, but there's a huge problem comparing all these studies because we have differences in composition, we have different in the kinematic release, we have differences in the manufacturing methods, and we also have inter- and intra-individual differences. If you look at the clinical data, this is a systematic review from 2016, only level 1 studies. 10 studies, 7 did not find any difference between using PRP and not using PRP. Only 1 did find a better outcome in the control group, and 2 did better with PRP. If you look at the next one, they used level 1 and level 3 studies. Also, 8 showed no difference, 3 had a lower tear rate, 1 increased vascularity, and only 1 study had significant better clinical outcomes than the control group. So, PRP for biological enhancement, we have no evidence for that. If we go to the stem cells, what is a stem cell? I think, first of all, we have to define what is a stem cell. It has been emphasized that all of our mesenchymal stem tissues contain the same cells. This is wrong. As of today, there are no ubiquitous stem cells in the mesenchyme. So the current definition is that we have differences in each tissue. So we have bone marrow specific cells, adipose specific cells, and so on. So you should only call it a stem cell if we have done extensive experiments and confirmed that it is of self-renewal and capable of differentiation into all soft tissue types. And the only type of cells we can call stem cells are the bone marrow-derived stem cells. The other we should call stroma cells. So you see, it's much more complicated with you think talking about stem cells. But if you look at the review and meta-analysis, a combination of basic and clinical science, we have 22 studies, only 3 in humans, and they could show that the use of stem cells showed less pain with stem cells, better scores, and biomechanics in favor of the stem cell group. If you look at the clinical evidence, level 1 to level 4 studies, 11 studies, only 4 on the shoulder. Tendon integrity is better, clinical scores better, and the re-tear rate is less compared to the control group. So we used this approach in our own setting. When I was with Gus Masaka in Connecticut, we used an experimental approach, harvesting bone marrow aspirate from the footprint site, preparing it, and then augmenting the revision rotator cuff repair. So this is an augmentation between tendon and footprint. It's not on the top. So as you can see here, it's a nice clot formation between tendon and cuff and footprint. Our results showed good clinical outcomes in all these patients pre-op and post-op, but we could not find any significance or any correlation between the amount of stem cells, the amount of nucleated cells. The only thing we could show that if you have high nucleated cells, you have less pain. But I think because of the low number, this has to be looked carefully. So stem cells for biological enhancement, maybe. I think we have too little data for that. And now I want to talk about vitamins, and especially on the vitamin D, which is, I believe, a very important vitamin in cuff repair. We know it's an vitamin that's used to downregulate an anti-inflammatory effect. It's also used in bone healing. We know that fracture-related bone mineral density is always also treated with vitamin D. We also know that it's used in muscle healing. And the most important thing, that is the tendon to bone scar. It's much better or much stronger in these studies showing with patients with normal vitamin D levels. So this is a study, a clinical evidence on 366 patients comparing 228 versus 138 patients. So this was a full thickness tear group, and the other group had no tear in the cuff. And they all underwent the MRI and isokinetic muscle performance, and serum level of vitamin D was measured. And they correlated that the vitamin D level was correlated to the supraspinatus tendon, to the infraspinatus tendon, and to the subscapularis tendon. So you can see the vitamin D level affects tendon and the fatty degeneration, and all showed low serum levels of vitamin D. This, on the other hand, a study out of Korea, only 91 patients compared to the other one. They could not find any correlation between the tear size, the retraction, or the fatty infiltration of the cuff muscle. But they could show that that 88% of these patients had low vitamin D levels. What about painkillers medication? I think most of us know this study about ibuprofen or these NSAIDs. We know that from this rat model that we have a reduced ultimate load to failure in this model using ibuprofen in the first weeks, and therefore it is not recommended in this model because they could show that if you give it afterwards, there's no difference in the load to failure compared to the control group. So you see biological augmentation is an open field. We have many things investigating at this time. We have gene therapy, we have stem cells, we have collagen-rich extracellular matrices, we have growth factors. I think there's still much to look for. The take-home message for today is microfracturing, so bone marrow stimulation, reduces retear rates. PRP, we don't have any clinical evidence for the stem cells, maybe, but at this point we have too little data. The steroids or the NSAID, not after surgery, at least for 3 to 6 weeks. And this is my personal recommendation, vitamin D for 3 months after surgery. Thank you.